All right, everyone, welcome. So think about this. A patient walks into your clinic one day with a classic case of the flu, or maybe shingles. What do you reach for? Well, today we're going to stock your mental toolbox with the essentials, the non-HIV antiviral drugs you'll be using to combat some of the most common viruses you'll encounter in your career.
This really is the million-dollar question in virology, isn't it? Viruses are the ultimate squatters. They're what we call obligate intracellular parasites, which is just a fancy way of saying they can't survive on their own. They have to hijack our cells' machinery to make copies of themselves. So the challenge becomes, how do we attack the virus without causing a ton of collateral damage to our own healthy cells? It's a tough problem, but we've come up with some incredibly clever solutions. So here's our roadmap for today. We'll start with why viruses are such a tricky enemy. Then we'll get into the specifics of fighting influenza, controlling those persistent herpes viruses, and tackling chronic hepatitis. We'll also cover the crucial topic of what to do when our drugs don't work anymore. And then we'll wrap up with a quick look at some other key players in the antiviral world.
Okay, let's get into the core concept here. In pharmacology, the holy grail is something called selective toxicity. All that means is we want to poison the bug, not the patient. Simple enough, with bacteria, right? They have cell walls, different ribosomes, plenty of unique targets. But viruses? They're using our stuff to replicate. They're masters of blending in. So the whole game is about finding that one little piece of machinery, that one enzyme that is unique to the virus and hitting it hard.
First up, an old classic you're all going to see every single year: influenza. When we go after the flu, we have a two-pronged attack plan. We can either stop the virus from making copies of itself inside the cell, or we can prevent all the brand new viruses from breaking out and spreading to other cells. And this image lays out those two strategies perfectly. On one hand, you've got your endonuclease inhibitors. Think of these as saboteurs throwing a wrench into the virus's photocopier. It just can't make any more copies. Then, on the other hand, you have the neuraminidase inhibitors. These guys are like security guards blocking the exits. The new viruses are made, but they're trapped inside the cell, unable to escape and cause more trouble.
Okay, so here are your main players. Oseltamivir, you'll probably know it as Tamiflu, is your first-line workhorse. It's a neuraminidase inhibitor. It blocks that viral release, and it's got a long, proven track record. Then you have balotsavir. This one is second line, and it works by stopping replication. Now here's its big selling point. It's a single dose. One pill and you're done. You can imagine how much better that is for making sure patients actually take their medicine.
Now, if you remember only one thing about treating the flu, make it this: 48 hours. That's your window. You have to start these medications within 48 hours of the first symptom. Why? Because after that, the virus has already replicated so much it's thrown a massive party that the drugs just can't keep up. So please, burn this number into your brain. It's a huge clinical pearl. All right, moving on from the flu, let's talk about a family of viruses that, well, they like to move in and never leave: the herpes viruses. We're talking about HSV, which causes cold sores, VZV, the chickenpox and shingles virus, and the more serious CMV. Our main weapon against them is a really clever class of drugs called guanosine analogs. Basically, they're counterfeit DNA building blocks that we trick the virus into using, which then grinds its replication machinery to a halt. So these are the four names you absolutely need to know. You've got acyclovir and ganciclovir, which are the active drugs. But you'll also see valacyclovir and valganciclovir. Notice the val prefix? That tells you it's a prodrug. A prodrug is just an inactive version of the medicine that our body has to activate. And there's a really good reason we do this. And here's why that prodrug strategy is so brilliant. You take the inactive drug, let's say valacyclovir, as a pill. It's designed to be absorbed really well from your gut. Then, as it passes through the liver, it gets converted into its active form, acyclovir. The end result? You get way more of the active drug into the bloodstream than if you had just taken acyclovir itself. It's a fantastic little trick. And this just puts it in black and white. Valacyclovir gives you 3 to 5 times better bioavailability. What does that mean for your patient? It means instead of taking a pill maybe 5 times a day, they might only have to take it once or twice. And let me tell you, that makes a world of difference when it comes to people actually finishing their prescription. Pay attention, because this is a super important point. It's a classic exam question. Acyclovir is your go-to for standard herpes simplex and for VZV, shingles. But when you're fighting cytomegalovirus or CMV, acyclovir just doesn't cut it. You need the bigger gun. Ganciclovir is much more effective against CMV's specific enzymes. So for CMV, you think ganciclovir
or valganciclovir. Got it?
Okay, let's shift gears now. We've talked about acute infections, but now we're moving into the world of chronic viruses, the ones that cause long-term damage, specifically to the liver. We're talking about hepatitis B and C. For hepatitis B, our main oral agents are entecavir and adafovir. Then there's another player you should know about, interferon alpha-2b. This one can be used for both Hep B and Hep C. Interferon is a bit different. It's not a direct-acting antiviral. Instead, it works by kicking your own immune system into high gear to help it find and destroy the virus.
Here is one of those small details that is anything but small in practice. For entecavir, you have to tell your patients to take it on a completely empty stomach. We're talking at least 2 hours after their last meal. Why? Because food dramatically reduces how much of the drug gets absorbed. Forgetting this simple instruction can be the difference between a treatment that works and one that fails. So just like with antibiotics, we inevitably run into resistance. A virus can mutate and suddenly our go-to drug like acyclovir just stops working. And when that happens, we can't just keep upping the dose. We have to pivot to a completely different mechanism of attack.
So meet your backup plan, foscarnet. This is our heavy hitter for resistant herpes viruses. Now remember how acyclovir needs a viral enzyme to activate it? It's like a key that needs to be cut by the virus. If the virus changes the lock, that key is useless. Foscarnet doesn't play that game. It's like a master key. It bypasses that activation step and goes straight to the viral DNA polymerase, shutting down replication directly.
And this algorithm shows you exactly when to bring in foscarnet. So you have a patient, likely someone who is immunocompromised, with a serious herpes infection. You've given them IV acyclovir, and they're still not getting better. That's your trigger. That's when you switch to IV foscarnet. It's your critical second-line agent for these tough, resistant cases.
Okay, to wrap things up, let's do a quick lightning round of some other important antivirals you should have on your radar. I mean, this field is always changing, especially as new viruses like the coronaviruses pop up and force us to innovate.
This table is a really nice high-yield summary. You've got ribavirin, an older drug we use for RSV in kids and sometimes for Hep C. Then, of course, the ones that have been all over the news, remdesivir, a nucleotide analog, and the combination nirmatrelvir plus ritonavir, Paxlovid, which is a protease inhibitor. Both of those have become cornerstones in our fight against SARS-CoV-2.
And that really brings us to the final thought. This whole field is a constant arms race, right? It's our scientific ingenuity against billions of years of viral evolution. As you all start your careers, you're going to see new drugs, new viral threats, and new strategies. You'll be on the front lines of this battle. It's an exciting and honestly a never-ending challenge.